diagnosis, even though I bet a lot of your patients or even you are experiencing medication overuse headache. So, how do we deal with them? Okay, so this is my disclosure. So, why is it important to educate ourselves about MOH? Because at the time of medical presentation of MOH, patients already had headache disorders for 20 years and with medication overuse for around 6 years. So that's the reason why we need to be educated about medication overuse headaches. Also, to prevent our patients from experiencing the vicious cycle. So what is that vicious cycle? So first, your patients would go to you complaining they have frequent intake of medications to alleviate the headache. So what do you think would that result to? Medication overuse, frequent intake of acute medications, and then medication overuse, which would result to increased headache frequency. So technically, this slide is the definition of what medication overuse headache is. Frequent intake of medications causing medication overuse, resulting to increased headache frequency, causing your patient to actually frequently use the acute medications again, medication overuse, blah, blah, blah. But this is the vicious cycle of medication overuse headache. Okay? So, awareness on the existence, clinical characteristics, and diagnosis of MOH, and prevent the vicious cycle of increased headache frequency and increased acute medication intake. So these are my objectives. I will define MOH, overview of the pathophysiology of MOH, discuss the clinical presentation and diagnosis, explore effective management strategies, and discuss the prognosis. So for the definition of MOH, so it is a secondary headache. So as you all know, your headaches, they would be having primary headaches and secondary headaches. Primary headaches are headaches which you don't actually know the cause. Examples would be migraine, tension type headache, cluster headache, and your secondary headaches would be the headaches that would actually have causes, like headache secondary to a ruptured aneurysm. Medication overuse headache is a type of secondary headache. So MOH, as mentioned, is a secondary headache disorder caused by overusing acute headache medications in patients with an established or underlying headache disorder. So before you actually diagnose your patients with MOH, even though they're overusing the acute headache medication, it's always important that your patient would have an underlying or established headache already. The normally usual established headache disorder would be migraine and tension type headache. So it is an interaction between a therapeutic agent excessively used and a susceptible patient. So for the history, it was actually first described in 1951 by Peters and Horton in their study entitled Headache with Special Reference to the Excessive Use of Ergotamine. During this time, it was ergotamine which was usually taken by the patients. Okay? So as you all know, I think you use these terms in your clinic. Some related terms used to define MOH before was analgesic headache, drug-induced headache, headache induced by chronic substance use or exposure, medication misuse headache, and rebound headache. So before the term medication overuse headache, these were some of the terms that are actually used to describe the diagnosis. And me personally, before actually being aware of MOH, I usually use the rebound headache. So the first edition of the International Classification of Headache Disorders actually classified MOH as a secondary headache. So the recent or the current ICHD or International Classification of Headache Disorders gave diagnostic criteria already for MOH. So first, you should have headache occurring on more than or equal to 15 days per month. So, as mentioned, the patient should have a pre-existing headache disorder, either a migraine, tension type headache, cluster headache, but usually a primary headache. So, the patient should have a regular overuse of the acute medication for more than 3 months of one or more drugs that can be taken for acute or symptomatic treatment of headache, and then not better accounted for by another diagnosis. So these medication overuse headaches, they actually group them into the acute medication type taken by the patient. So these are the medication types under the ICHD. You have your ergotamine overuse, you have your triptan overuse, non-opioid analgesic overuse, opioid overuse headache, and the combination analgesic overuse headache. So if you read your ICHD 3, they actually grouped it into several sections, okay? So what's the important thing about grouping it into several sections? Because the number of days of intake of the acute medications is different per acute medications. So for instance, regular intake of 10 days per month for 3 months and regular intake on 15 days per month for 3 months. So what are the acute medications under regular intake on 10 days per month for 3 months? So you have your ergotamine, triptan, opioid, and combination analgesic. So this means if your patient presenting to you at your clinic who has a history of taking ergotamine, triptan, opioid, or combination analgesic for 10 days per month for 3 months, you can diagnose them as medication overuse headache secondary to either ergotamine, triptan, etc. So for those patients with regular intake of 15 days per month for more than 3 months, medications are the non-opioid analgesic overuse headaches, which are your paracetamol, your acetyl salicylic acid, and your NSAIDs. I think in your clinic, these are the diagnoses you usually see. So if the patient goes to your clinic with history of taking NSAIDs for 15 days per month for more than 3 months for a migraine, you can diagnose them as MOH secondary to NSAIDs overuse or non-opioid analgesic overuse. So for the overview of the pathophysiology of MOH, a 20-minute lecture wouldn't be enough. Actually, it's a whole day lecture. So I'll just do an overview of the pathophysiology of MOH. So it's a well-described clinical diagnosis, and it is well-established link between regularly taking acute medication and increasing headache frequency. However, there is an incomplete understanding of its pathophysiology. So as you all know, it's a complex headache disorders involving many factors. So you have your genetic aspects, you have your behavioral and psychological factors. So there are actually many studies relating medication overuse headaches to substance abuse. And then you have your sex-specific factors. Is usually medication overuse headaches are usually seen in females, especially in premenopausal females, because that is when their hormones are changing, causing them to have increased migraines. And then you have structural and functional brain changes, and then alteration and pain processing. So these are the factors involved in actually causing the medication overuse headache in patients. So, sorry, I forgot to mention there's also a change in cortical excitability. So it's an interplay between biological factors, psychological factors, and the most important is the overuse of your acute medications. So for the clinical presentation and diagnosis of MOH, most MOH patients have migraine or tension type headache. So actually, tension type headache and migraine is one of the most common primary headache. Tension type being the first, migraine being the second. So it's medyo obvious why it is why most MOH patient would have these primary headaches. So they have variable clinical features, so frequency, characteristics, and durations. Okay, so Frequency, you would be having more frequent headaches. If your patient has MOH, he would be complaining of more frequent headaches. Characteristics and duration affected by the type of the underlying headache and overused medication. So your MOH doesn't have specific clinical characteristics. The most specific clinical characteristics of patients with MOH is that they complain of more frequent headaches. But in terms of characteristics, it depends on the underlying headache. If the patient has migraine tension type cluster, and if the patient, what kind of medication the patient overuse. Okay? So according to this study, features of medication overuse headache following overuse of different acute headache drugs, they found out that in patients overusing ergos, the usual presentation of their patients with MOH is actually band-like. The patient complains of daily tension type-like headache. While in patients who overuse analgesics, like your paracetamol, their patients actually complain, same thing, with tension type-like headaches. It's very interesting because um, 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 it's very different. Okay, so like this, in patients overusing triptan, the patient doesn't complain of tension type headache, but actually daily migraine like headache and increase in migraine frequency. So, as mentioned before, MOH, they have same frequency, meaning they have increased frequency, but in terms of characteristics and duration, it usually depends on the underlying headache disorder and the overused acute medication of the patient. Okay, in another study, clinical characteristics of medication overuse, headache according to the class of acute medication, so it's a cross-sectional multicenter study. They found out that patients overusing ergos and overusing multiple drug classes, the patients presented with more frequent use of acute medications and then fewer headache-free days. So technically, this is a study in Korea. So I studied in Korea. They usually, unlike in the Philippines, when they actually prescribe medications, it's actually combined. Kasi dito, di ba, sometimes we try one medication. If it doesn't work, we change it to another. But in Korea, they usually combine low doses medications. Okay? So they found out if the patients actually overuse those multiple drugs given to them, the patients actually complained of more frequent use of those acute medications and fewer headache-free days. For the diagnosis, I mentioned this is the ICHD diagnostic criteria for MOH. And then the regular intake on 10 days per month, I'll just repeat. You have your ergotamine, triptan, opioid, and combination analgesics. Examples of your combination analgesics would be your paracetamol plus caffeine, okay, etc. And your orphanadrine plus paracetamol. And for the regular intake on 15 days per month for more than 3 months, you have your non-opioid analgesic overuse headache, like your paracetamol and NSAIDs. So for the diagnosis of MOH, it actually requires complete and thorough history taking and examination. So this includes red flag signs. So it's very important, else I can't stress it enough. When you see patients with red flag signs, you don't consider them having primary headaches. You always consider them to have secondary headaches. And then headache diaries. This is very important. Okay, I don't know if you do it in your clinics, but I suggest that you do it in your clinics. Headache diaries for diagnosis and measure treatment effects, including frequency, severity, medication use, and other associated symptoms. For to explore the effective management strategies, there is still no specific treatment for MOH. So there are a lot of studies in different countries wherein they tried to actually explore the effective management strategies that can be used for MOH. So several aspects of MOH management include patient centricity and education, withdrawal of the overused medication, behavioral intervention, preventive treatment targeting MOH and underlying primary headache, So those are the treatment strategies actually presented. There is no definite treatment for MOH, but the countries who actually did the study on it, those are the suggested strategies. Okay, so selection of therapy of MOH management. Since I mentioned that there are limited studies on it, it cannot be based on the evidence absolute strength due to limitations in studies and study designs, but based on characteristics of patients, which includes medical and psychiatric comorbidities. So first, your patient centricity in education. So this is actually the first step in management of MOH. Education and patient engagement to promote MOH awareness and treatment motivation. So next is pausing or withdrawal of medication. Okay, so this is actually the most accepted. You suddenly abruptly discontinue the acute medications of the patient. So discontinuation or limitation of overused medication. So strategies for stopping or limiting overused medications, these four strategies are actually the ones studied. First, you have early discontinuation of the overused medication without preventive treatment. It means you just stop it without giving other medications. Second is the early discontinuation of the overused medication, plus you give preventive medication. Third is the preventive treatment with restricted use of the overused medication. So you give a preventive medication and then you restrict, you limit the use of the acute medication. And fourth, the preventive medication without early discontinuation or restriction of the overused medication. So you just allow the patient to use the overused medication plus giving a preventive. So there are actually two studies which actually compared those strategies. So in the first study, they found out that early discontinuation plus preventive medication is stronger or better than early discontinuation alone. The second study showed also the same results. Discontinuation plus preventive medication is better than discontinuation alone and preventive medication without discontinuation. Okay, so triptans, ergot, and simple analgesics or NSAID, you can abruptly discontinue it. So it is recommended, safe, and tolerated in most patients. However, if you have patients who overuse opioids and barbiturates, you just taper it very slowly to avoid withdrawal symptoms. So withdrawal headache. So if you see a patient wherein you abruptly stop the medications, obviously most of them would complain of withdrawal symptoms. So withdrawal headache felt during acute phase of drug discontinuation may challenge discontinuation. So what do we do? What do we do? So there are strategies to actually reduce this withdrawal. You can give systemic steroids, regular use of celecoxib, intravenous paracetamol, and other drugs used for status migrainosus. So when you actually abruptly discontinue a patient, the patient would complain of withdrawal headache. You can actually do these strategies to reduce the withdrawal. So, preventive treatments, pharmacological, recommended for the initial treatment phase of MOH. So, you give the pharmacological or preventive treatments before, during, or after medication discontinuation. So, prophylactic medications with efficacy against MOH. So, not all prophylactic medications have studies which prove them effective against MOH. Hello. Parang international conference lang. Overtime na off yung mic. Sorry, patapos na ako. This is very important. So anyway, prophylactic meds that actually can be used against MOH. You have your topiramate, valproic acid, Botox, CGRP monoclonal antibodies in Japan. So these are actually, they have studies. And then others that you can also use, however, they don't have studies but can be used in clinical practice are beta blockers, flunarizine, tricyclic antidepressants, and candesartan. So interventional therapies, you can actually use greater occipital nerve blockade with 1% lidocaine. And then for the non-pharmacological, you can use behavioral interventions, acupuncture, and neuromodulation. So follow-up treatment is very important to actually make sure that your patient is actually complying to what you gave. So I wouldn't explain this one by one, but this is a very good slide by Dr. Ishina and his other researchers wherein they presented an algorithm on how to treat MOH. Okay, so the prognosis of patients with MOH, generally good short-term prognosis. So no medication overuse among patients. 66 to 100% of patients at 2 months, 60 to 83% of patients at 1 year after withdrawal, particularly with preventive medications. So in managing your patients with MOH, abrupt withdrawal plus preventive is the most effective. So, however, 10 to 40% of patients may relapse. Okay? So, the most crucial time period to predict long term success is the first year after withdrawal. Hence, the first year after your abrupt withdrawal, you should do close follow up because there is a high relapse rate. Okay? So, controversies on MOH. So, what is the actual number of patients with MOH? Definition of MOH implies causality, even though cause and effect in MOH is not yet certain. Stigmatize the term overuse, so parang sinisisi mo yung patient mo kung bakit siya nagka-MOH. Studies on withdrawal are mostly uncontrolled, no standardized management procedure, and not all patients benefit from withdrawal procedures. So since there is limited studies on MOH, there are still lots of controversies on MOH. But despite controversies and uncertainties in MOH, it is important to educate ourselves about MOH for awareness on the existence, clinical characteristics, and diagnosis of MAH, and prevent the vicious cycle. Since, as what Dr. Rojas says, headache robs you of the joy of living. So these are my sources, and thank you.